You know, it's the most common cancer among men right here in the Netherlands, but trying to figure out if you should even look for it, that can feel like you're lost in a maze.
It really can.
Yeah.
And it's a topic that's just full of these critical nuances, and for very good reason. The science is always moving, challenging things we thought we knew.
Absolutely. So welcome everyone to the deep dive. Our mission today, we want to cut through all that noise, really. We're digging into the latest insights from the Dutch National General Practitioners Guideline, the NHG standard, fresh from September 2024.
Yeah, the goal is to arm you, our listener, with the crucial facts about prostate cancer. Diagnosis, screening, treatment choices, all of it.
We want you to walk away feeling genuinely informed, but importantly, not completely overwhelmed by it all.
Exactly. We'll unpack the tricky bits, like the decision around early testing, what the diagnostic process actually looks like now, including, newer tech like MRI, and the real-world impact of different treatments.
Okay, so let's start this deep dive. First up, maybe just a clear snapshot. What does the landscape of prostate cancer actually look like right now?
Well, the first thing that jumps out is just how common it is. We're talking nearly 1 in 5 of all cancer cases in men in the Netherlands. It's the most common type for men, period.
1 in 5. That's significant.
It really is. And the risk climbs dramatically with age. For men aged, say, 50 to 55, it's around 20 per 100,000 each year. But get up to 75 to 80, it rockets to 400 per 100,000.
Wow, that's a huge age-related jump. And what about the overall impact? Mortality?
Well, looking at 2021 data, about 3,000 men in the Netherlands died from prostate cancer. That's roughly 12% of all male cancer deaths. But, and this is really key, how the disease progresses varies a lot.
Okay.
Big insight is that around 60%, so the majority, are diagnosed when the cancer is still localized, just confined to the prostate. And a good chunk of these might never actually cause any symptoms or problems during a man's life.
Wait, so 60% are localized, and many of those might never be an issue. That kind of turns the usual thinking about cancer detection on its head, doesn't it?
It really does. It forces us to reconsider things. Now, about 20% are locally advanced when found, and maybe 15% have already spread metastasized, usually to bones or lymph nodes.
Okay.
And another important point, it usually grows slowly, often right on the edge, the periphery of the prostate, away from the urethra, meaning urinary symptoms like trouble peeing. They're actually rarely an early sign. If you do get symptoms like, say, unexplained bone pain, especially back and hips, or you're losing weight without trying, feeling generally unwell, that could point towards more advanced disease.
So the common idea that urinary trouble means early prostate cancer, that's often wrong.
Often, yes. And for those localized cases we mentioned, the prognosis is actually remarkably good.
How good?
The relative 10-year survival rate is over 95%.
Over 95%. That's huge. It really underlines why understanding the nuances is so critical, doesn't it? Especially when thinking about finding it early.
Precisely. It challenges our whole approach. But before we dive deeper into that dilemma, maybe we should nail down some key terms, just make sure we're all on the same page.
Good idea. Language matters here. Let's start with one everyone's heard of, PSA.
Right, PSA, prostate-specific antigen. It's an enzyme the prostate makes, and we can measure it in the blood. But here's the catch. The level can go up for lots of reasons. Age, sure, but also prostate inflammation. That's prostatitis, or just a benign enlarged prostate, BPH, and yes, prostate cancer too.
So a high PSA isn't a smoking gun for cancer. It's just a signal.
Exactly. It's not cancer-specific. That's the key takeaway.
Got it. Okay, next up. Early diagnostics versus screening. These get mixed up all the time, right? Even in, medical circles sometimes.
They do. So early diagnostics, that's when you, the patient, ask for a test, even though you don't have symptoms. Maybe you're worried, wanting to check things out. It's sometimes called opportunistic screening.
Okay, patient-driven.
Right. That's totally different from systematic screening. That's where, say, the health system actively invites whole populations for testing, like with breast or bowel cancer screening. And the crucial point here, in the Netherlands, large-scale systematic screening for prostate cancer is not recommended.
That's a really important distinction. It puts the ball more in the individual's court, in a way. Okay, now, aggressiveness. How do doctors figure out how serious a cancer is? I've heard of Gleason scores.
Yeah, the Gleason score, or GS, it's been around a while, goes from 2 to 10. It basically looks at how abnormal the cancer cells look under the microscope. A GS of 6 or less, that's generally favorable. 7 is moderate. 8 to 10, unfavorable.
Right.
But there's a newer system now, which is frankly much clearer, the ISP grade groups. Goes from 1 to 5.
And how does that help clarify things better for doctors, but also for patients trying to understand their diagnosis?
It just refines the risk categories in a much more clinically useful way. For instance, all those Gleason 6 scores, they all just fall neatly into grade group 1, low risk. A Gleason 7 score used to be tricky, but now 3 plus 47 is grade group 2, while 4 plus 3, 7, which is actually more aggressive, is clearly separated as grade group 3.
Ah, okay, so it removes some of that ambiguity around Gleason 7, makes the risk level clear.
Exactly. It just makes the whole stratification much more straightforward and actionable.
Makes sense. And if the cancer is found to be non-aggressive, low risk,
Yeah.
what happens then? Are there different ways to manage it without jumping straight to, say, surgery or radiation?
Yes, absolutely. And understanding these is critical. There are two main approaches for these less aggressive localized cancers: active surveillance and watchful waiting.
Okay, active surveillance first. What's that involve?
So active surveillance is for men with localized low-risk cancer who are otherwise suitable for curative treatment but don't need it right now. It's a very structured follow-up plan. Regular PSA tests, rectal exams, MRI scans, sometimes targeted biopsies.
So you're watching it closely.
Very closely. The whole idea is that you only start curative treatment if the cancer shows clear signs of progressing. The goal is to avoid overtreatment for these slow-growing tumors that might never cause harm and preserve quality of life.
Okay, so careful monitoring, only treating if it changes. How is watchful waiting different then?
Watchful waiting is quite different. It's generally for patients who, right from the start, aren't really candidates for curative treatment, maybe because of their age or other serious health problems.
Right.
It's essentially a palliative approach. You manage symptoms as they arise. Treatment, often hormonal therapy, only starts when the cancer actually causes problems. The aim isn't cure, it's symptom relief and maintaining the best possible quality of life.
That's a really crucial difference. One delays potential treatment, the other accepts treatment isn't the goal. Which brings us right to, well, the heart of the matter for many men, doesn't it? Should you even get tested in the first place?
This is where it gets really complex. The latest guidelines, they draw on these huge studies, ERSPC, PLCO.
The big European and American screening trials.
Exactly. And what they consistently show is that systematic PSA screening, testing everyone across the board, it doesn't significantly reduce overall deaths. Full stop.
Doesn't reduce overall deaths. Okay. What about deaths specifically from prostate cancer?
There, the picture is, well, it's murky. Some analyses suggest maybe a small reduction in prostate cancer deaths, perhaps one less death per 1,000 men screened over 10 years. But often, even that small effect isn't statistically significant. And crucially, it comes with some major downsides.
1 death per 1,000 over a decade. That sounds like a very small potential benefit. What are these major downsides?
The absolute core issue is overdiagnosis and overtreatment. This is huge. Screening picks up a lot of these slow-growing grade group 1 type cancers that frankly would never have caused any harm if they'd just been left alone.
They're overdiagnosed.
Precisely. And when you find these cancers, the tendency is to treat them. That's overtreatment. So you're exposing men to potentially serious side effects, incontinence or erectile dysfunction, from treatments they never actually needed to live a long life.
That's a really difficult trade-off. The side effects can severely impact quality of life, can't they?
Absolutely. Studies suggest the hit to quality of life from diagnosis and treatment complications can basically wipe out any tiny potential survival benefit from the screening itself.
Wow. So the very act of looking for it could lead to a worse outcome in terms of daily life.
It certainly can for some men. Now, there's a really important caveat here, something we need to stress.
Okay.
Most of those big screening studies we mentioned, they were designed and run before MRI became widely used and refined for prostate diagnosis.
Right. You mentioned MRI was a game changer.
It is. So the diagnostic landscape is changing, even if the advice against mass population screening hasn't shifted yet. MRI helps us target biopsies better, potentially find more significant cancers and fewer insignificant ones. But the older screening studies didn't have that tool.
That's a crucial piece of context. So given all this, the lack of clear mortality benefit from mass screening, the huge risk of overdiagnosis, but also the advent of better tools like MRI, what does this mean for an individual man thinking, should I get a PSA test?
It means it boils down to a very personal decision, and one that absolutely requires a thorough chat with your doctor. Real, shared decision-making.
What should that conversation cover?
The doctor needs to lay out the pros and cons clearly. The small chance of finding a truly aggressive cancer earlier versus the much larger chance of finding an indolent one that leads to unnecessary treatment and side effects.
It's tough, isn't it? Psychologically, the urge to find it early must be incredibly strong.
It is. Many men, understandably, feel relieved when a cancer is found. They think, okay, except the side effects, the cancer is cured. But that thinking often completely misses the reality that the cured cancer might have been one that was never going to cause harm anyway.
Falling into the trap of thinking any cancer found is a win, even if the win comes with life-altering consequences.
Precisely. And that's why things like patient decision aids are so valuable. Resources like thusarts.nl, they provide evidence-based info, help you understand the trade-offs, get more involved in making a choice that's right for you.
Empowering people with good information, that seems key. Okay, let's shift slightly. Say, after that discussion, someone does decide on testing. Or perhaps there's already a reason to suspect prostate cancer. What happens next? What's the actual diagnostic path look like?
Okay, so who gets tested? Generally, it's men who specifically request early diagnosis after that detailed counseling, and crucially, who have a life expectancy of at least 10 years. Usually means under 75.
Right, because treating a slow-growing cancer might not make sense if other health issues are more pressing.
Exactly. Also, men known to carry a specific genetic risk factor, the BRCA2 variant, we'll circle back to that. And then, of course, men where there's a clinical suspicion, like unexplained bone pain suggesting spread, or if the doctor finds something abnormal during a rectal exam.
Ah, yes, the digital rectal exam, or DRE, the physical check. What's its role these days?
The DRE, yes. The doctor feels the prostate for lumps, hardness, asymmetry. Look, its value as a standalone screening tool is debated, but it definitely can help detect prostate cancers, especially some of the more aggressive ones. And just practically doing a DRE before a PSA blood test doesn't really affect the PSA level in any meaningful way.
Good to know. Okay, so the PSA test is done. How are the results interpreted? What did the numbers actually tell you?
If the PSA comes back very low, less than 1 nanogram per milliliter, NG-MAWL, the risk of having a significant prostate cancer is tiny. For men under 60, the advice is maybe recheck in 5 years, but no sooner. Over 60. No need for further routine checks based on that result.
Okay, so under 1 is pretty reassuring. What about slightly higher but still low, say between 1 and 3?
PSA, between 1 and 3 in GLRs. Still considered low risk. Generally, no further investigation needed right away. If you do choose to retest down the line, wait at least 2 years.
Right. Now, the threshold for more concern.
That's generally considered to be a PSA of 3 in GLR or higher. But, and this is important, hitting 3 or more does not automatically mean cancer. Remember, infection or just BPH can raise it too.
So what happens if it is 3 or higher and there's no obvious infection?
Well, if there might have been a recent urinary tract infection or prostatitis, the doctor will usually recheck the PSA after about 12 weeks, once things have settled. If there's no sign of infection or the PSA is still high on the recheck, then referral to a urologist is the next step.
And this is where the MRI comes in more formally.
Yes. The strong preference now, according to the guidelines, is to refer the patient to a center that uses prostate MRI as part of the diagnostic workup.
Okay, let's really unpack this MRI piece. You called it a game changer. Why? What does it actually do better?
It's typically used after the elevated PSA, before deciding on biopsies. And its impact is massive. Firstly, it significantly cuts down on unnecessary biopsies. If the MRI is clear, negative, about 29% fewer men need to undergo biopsies compared to the old approach.
Nearly a third fewer biopsies. That's huge given the risks of biopsies, right? Infection, bleeding.
Exactly. Biopsies aren't risk-free. There's a 1.8% risk of infection, even up to 4% risk of serious sepsis in some studies, plus bleeding, pain. Avoiding that for almost a third of men is a major step forward.
Okay, fewer unnecessary biopsies. What else?
MRI is also better at spotting the clinically significant cancers, the ones that actually need treating. And importantly, it's less likely to pick up the very small, low-grade, clinically insignificant cancers.
So it helps tackle that overdiagnosis problem we talked about.
Precisely. It helps focus treatment on the cancers that matter. Plus, if the MRI does show suspicious areas, biopsies can be targeted directly at those spots, making them much more accurate than the older method of just taking systematic samples from all over the prostate.
More accurate, fewer side effects, less overtreatment. It sounds like a win-win-win. Is there a downside?
The main thing is quality control. The usefulness of the MRI depends heavily on the quality of the scanner itself and, really importantly, the skill and experience of the radiologist reading it. Not all hospitals have the top-end equipment or specialized radiologists yet, so performance can vary.
So the technology is great, but implementation and expertise matter. That's worth asking about if you're referred. Okay, one more thing on diagnosis.
Yeah.
What about those online prostate calculators or risk tools you see sometimes? Are they helpful?
Yeah, the prostate wizards, they try to estimate your risk using factors like age, PSA, maybe family history.
Hmm.
But the current guidelines actually discourage using them in general practice,
Why is that?
mainly because they haven't really been properly validated for use in that primary care setting. And some of them tend to overestimate the chances of actually having cancer found on a biopsy, which could just lead to unnecessary worry or pressure for tests that aren't really needed.
Okay, so stick to the validated medical pathways, not necessarily the online algorithms. Got it. Now let's tackle something else that often causes confusion. Familial versus hereditary prostate cancer. They sound similar, but you said there's a key difference.
A really critical difference, yes. Familial prostate cancer just means you see more cases in a family than you'd expect by chance. Maybe 3 close relatives diagnosed, or maybe 2 relatives but diagnosed quite young, that sort of thing.
So it runs in the family, but maybe not for a single clear genetic reason.
Exactly. It's often down to a mix of shared genes, maybe shared environmental factors, or sometimes it's just coincidence. It's usually not linked to one specific high-impact gene mutation. And importantly, the guidelines say having just familial risk alone isn't a reason for routine PSA screening because we lack evidence it helps those men.
Okay, so family history alone doesn't automatically trigger screening recommendations. How
Mhm.
is hereditary prostate cancer different then?
Hereditary prostate cancer is much more specific. It means there is a known pathogenic germline variant, a specific inherited gene mutation that significantly ramps up the cancer risk.
A specific gene flaw.
Yes. And the most common one we know of in prostate cancer is in the BRCA2 gene.
BRCA2, isn't that usually linked with breast and ovarian cancer?
It's most famous for that, yes.
Yeah.
But it's absolutely crucial for prostate cancer risk too. Only about 5–10% of all prostate cancers are linked to a known hereditary cause like BRCA2. But for the men who carry that variant, the implications are really significant.
How significant? What does having a BRCA2 mutation mean for a man's prostate cancer risk?
Men with a pathogenic BRCA2 variant have about a 2.5 times higher risk of getting prostate cancer compared to the general population. Not only that, but when they do get it, it's often more aggressive, tends to develop at a younger age, and generally has a worse prognosis.
Wow, higher risk, more aggressive, younger onset.
Yes. And just as an aside, these men also have about a 7% lifetime risk of developing male breast cancer, which is much higher than average.
Okay, so for these men with a confirmed BRCA2 mutation, the advice about screening must be totally different.
Completely different. For men known to carry a pathogenic BRCA2 variant, routine screening is recommended. The advice is biennial. So, every 2 years, PSA testing and a digital rectal exam,
Starting when?
starting from age 45. Or, if there's a family history of prostate cancer diagnosed younger than 50, they should start 5 years before the age of the youngest diagnosis in the family. And this continues up to age 70.
And who initiates this? The GP, the geneticist.
The responsibility to actually go for the screening lies with the patient themselves, but the geneticists who identify the mutation will inform the patient and typically also their GP, so everyone's aware of the recommendation.
That's a much clearer, targeted screening approach based on specific genetic risk. Really highlights the power of genetic information in some cases. Okay, so let's move on. If a diagnosis is made, what are the actual treatment options? And what are the realities, the trade-offs men face?
Right. The treatment choice is super individual. Depends on the cancer stage, the grade, how aggressive it looks, but also really importantly, your overall health, your age, and what your personal priorities are. We already touched on watchful waiting and active surveillance for lower risk disease.
Yes. So what about treatments aiming for a cure?
The main curative options are generally surgery or radiation. First, there's radical prostatectomy that's surgically removing the entire prostate gland.
Okay. Effective for the cancer, presumably, but what about side effects?
It can be very effective, yes, but the side effects can be substantial. The big ones are urinary incontinence leakage, reported by around 56% of men afterwards to some degree, and erectile dysfunction, ED, which is very common, reported by about 83%. Bowel problems are less common, but can happen.
Wow, 56% incontinence, 83% ED. Those are very high numbers. That's a huge potential impact on quality of life.
It absolutely is, and it needs to be weighed very carefully. The other main curative route is radiation therapy. This can be external beam radiation, like high-energy X-rays from outside the body, or brachytherapy, where tiny radioactive seeds are placed directly inside the prostate.
And how do the side effects compare with radiation? Different challenges.
Radiation can also cause erectile dysfunction. The risk is maybe 7 to 22% higher than with active surveillance. And remember, active surveillance itself still has a baseline ED risk around 50% just due to aging and other factors.
So still a significant risk of ED with radiation too.
Yes, radiation can also cause temporary, sometimes longer-lasting bowel problems like irritation or bleeding. On the plus side, it generally has less impact on urinary incontinence compared to surgery.
So different profiles, but both surgery and radiation carry significant risks of altering urinary function, sexual function, or bowel function.
Definitely. Neither path is free of potential long-term consequences, and that's for curative treatment. If the cancer has already spread, become metastatic.
Then cure usually isn't the goal anymore.
Right. For metastatic disease, cure is generally not possible. The focus shifts to controlling the cancer, managing symptoms, extending life, and maintaining quality of life. The mainstay here is usually palliative hormonal therapy. It's called androgen deprivation therapy, or ADT.
Lowering testosterone levels.
Exactly. Because prostate cancer growth is often fueled by male hormones. Sometimes ADT is combined with chemotherapy or newer targeted drugs. But ADT itself has side effects: hot flashes, loss of libido, ED, muscle weakness, risk of osteoporosis, sometimes breast enlargement or tenderness called gynecomastia.
So even the palliative treatments have their own set of challenges.
They do. It really underscores the point. Every treatment decision involves balancing the potential benefits against the potential harms and side effects.
Which loops right back to that issue of overdiagnosis, doesn't it? Understanding these potential side effects makes you think very hard about treating a cancer that might never have caused problems in the first place.
It's absolutely critical. You need the full picture to make an informed choice. It's not just about getting rid of the cancer, it's about what life looks like afterwards.
So beyond the immediate treatment phase, what about longer term? Follow-up, aftercare. What does that involve?
Follow-up after treatment is usually managed primarily by the urologist. They'll monitor PSA levels, check for recurrence, manage ongoing side effects. Sometimes, if things are stable, the GP might take over some aspects, like giving hormone injections, but that's always in agreement with the urologist and the patient.
And this aftercare, or NESORG, what does that cover?
NOSRG is broader. It's about managing the long-term physical and psychological effects of the cancer and its treatment. It includes things like rehabilitation, maybe pelvic floor exercises for incontinence, psychological support, help with fatigue, really addressing those quality of life issues that can stick around.
Comprehensive support for the long haul. And what about work? Getting back to work must be a big hurdle for many men after treatment.
It really can be. Fatigue, concentration problems, ongoing side effects. It's a challenge. But there are specialized resources. In the Netherlands, we have occupational physicians called BSO's Bedrijfsarts Consulent Oncology. They specifically help cancer patients navigate returning to work.
That sounds incredibly useful.
It is. And there's also a great peer support available through patient organizations like the NFK, the Dutch Federation of Cancer Patient Organizations. They have ambassadors, often people who've been through it themselves, who can offer practical advice and support for getting back into working life.
Fantastic. Well, we have certainly covered a lot of ground today. It's a complex area, but so important. We've gone from the basics, how common prostate cancer is, how it often behaves, through the really tricky debate around screening, weighing those pros and cons.
Yeah, looking at why systematic screening isn't recommended, the problem of overdiagnosis, but also the role of individual choice and shared decision-making.
Exactly. And then diving into the modern diagnostic pathway, the impact of MRI, differentiating familial and hereditary risk, especially that BRCA2 link.
And finally, exploring the realities of treatment options, surgery, radiation, hormonal therapy, and importantly, their potential side effects and impact on life, plus the support available afterwards.
Our real hope here is that having this information, understanding these latest guidelines, empowers you to have better, more informed conversations with your doctor, to really weigh the benefits and harms and make choices that feel right for you.
Especially with a cancer like this, which, as we've seen, can often be very slow growing and might not even need aggressive intervention. Knowledge helps you navigate that uncertainty.
So let's leave you with a final thought to mull over. When we're talking about a cancer that's common, often grows slowly, and might never actually cause harm, does that powerful impulse we all have to find it early always align with what's best for our long-term health and our quality of life? How has digging into this today maybe reframed your own thinking about health, prevention, and perhaps learning to live with the degree of uncertainty?